Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Good afternoon. Before I start my presentation, I would like to thank the organizing committee for inviting me to participate in this Congress and to thank the members for the excellent preparation for this Congress. My task is to review with you the use of stem cells in solid organ transplantation. This will be in less than half an hour, and what I thought I will do is give you just the highlights without going in details and bother you with complicated basic research. Maybe look at the translational part of the research that has shown that we can use stem cells to facilitate solid organ transplantation. One would think that with the popularity of stem cells being pluripotent, with the plasticity that has been characterized in stem cells, and as you know, people are talking about developing organs from stem cells, one would think that it can facilitate solid organ transplantation, and I think there is evidence that it does. So this is an outline of my presentation. I'll give you a background, then we will try to define what is the stem cells that are characterized and they can facilitate the solid organ transplantation, specifically mesenchymal stem cells, and the immunosuppressive regenerative properties, and look at the clinical production, numbers of cells used, and if there is need for concurrent immune suppression at the same time when you give mesenchymal stem cells. Then we look at the feasibility and the safety of using mesenchymal stem cells in solid organ transplantation, and I will try to make the case for use of mesenchymal stem cells in solid organ transplantation. Now, just a brief background, you're all aware of the major problem that we face in solid organ transplantation is the graft rejection, and this is due to the recipient immune system reacting to the donor antigens. With the ischemia, reperfusion injury, you have also immune responses that will complicate it, and you could lose the graft. Now, if patients do well, then they need to have lifelong immunosuppressive therapy that has acute and chronic side effects. A lot of studies are done now to look at what is the most optimal therapy for immunosuppression in solid organ transplantation as far as the drug utilization for immune suppression. Many side effects, I'm not going to go into the details, but you all are aware of all the side effects that could happen to these patients. One would think that in principle, with the mesenchymal stem cells having immune suppressive properties and as well as regenerative properties, that they can facilitate solid organ transplantation. Now, what are the sources? And just briefly, as you can see, the list is long. You can get it from bone marrow, adipose tissue, skin, umbilical cord blood, placenta, heart, kidney, liver, spleen, but it is mostly characterized in the bone marrow. Now, we need to make sure that we're characterizing these cells when we use them, and we're identifying them properly, knowing all their characteristics. And that will include the morphology in culture, differentiation capacity, immune phenotyping, immunosuppressive capacity, and regenerative capacity. Just a brief background that would show that there is a lot of sense in considering these cells for facilitating solid organ transplantation. They've been used in inflammatory disease in various animal models for colitis, myocarditis, rheumatoid arthritis, autoimmune encephalitis. And there are many clinical trials to use mesenchymal stem cells in rheumatoid arthritis, inflammatory bowel disease, multiple sclerosis, and others. We as hematologists, we use mesenchymal stem cells in bone marrow transplantation. And we use it to facilitate engraftment and to reduce graft versus host disease. Actually, we use mesenchymal stem cells to treat the resistant graft versus host disease, like steroid resistant, or even GVHD that's resistant to specific antibodies. And we see that it does have good efficacy. And as you all know, bone marrow and kidney transplant have been both done at the same time and resulted in reduction or elimination of the use of immunosuppressive therapy. Now, there are many studies looking at the use of mesenchymal stem cells in solid organ transplantation. Animal transplant models have been shown that it prolongs survival of grafts for the skin, heart, liver, kidney. There are very few, I would say, studies that have not been really reproduced that showed it may accelerate graft loss, but this has not been reproduced and confirmed. And there are many clinical trials at the present time, phase 1, even phase 2, but mostly phase 1 studies. Knowing the importance of mesenchymal stem cells in solid tumor, there is a study group that has been established to look at the role of mesenchymal stem cells in solid organ transplantation. This study group has met 3 times. There are experts from different parts of the world in stem cells and solid organ transplantation. There are 3 meetings done, and each meeting produced a position paper about the status and the recommendation. First meeting was done 2008 in Germany, then 2010 January in the Netherlands, and in April, just last April, in Belgium. And there are position papers that have been produced and published in Transplantation. Now, just going over the characteristics of these cells. As far as morphology in culture, they look like, as you can see, they look like fibroblasts. Fibroblasts, they have adhesive properties, and that's important as far as their characteristics. They have differentiation capacity. They can differentiate. This is undifferentiated mesenchymal stem cells. They can differentiate into osteogenic or, adipose tissue, osteogenic or chondrogenic. This is adipose, this is osteogenic, and this is chondrogenic. Also, it has the capacity to differentiate into myogenic cells, and this has been done in cultures. Now, what about immunophenotyping? This has been well characterized by the International Society for inhibits the CD4, CD8 cells, and it has immune modulatory effect on the dendritic cells with respect to immature and mature dendritic cells, and this is critical in order to make sure that these cells have role in immune interactions. Now, as far as tissue repair, in the setup one, there is no pathogen-associated molecules. You could have anti-inflammatory and dendritic cell modulation with T-regulatory cell induction, and you could have non-fibrotic tissue repair. When you have pathogen-associated molecules, you may have the profibrotic tissue repair through the allogeneic immune responses. Now, this slide summarizes the efficacy of mesenchymal stem cells with respect to the induction of regulatory cells and also the inhibition of the naive and memory cells, while with respect to the dendritic cells, you have immune modulation for immature and mature cells, which is important in its function as far as facilitating solid organ transplantation. Now, one would think that having these characteristics, and I didn't go into details, it could facilitate using mesenchymal cells as cellular therapy in solid organ transplantation. Now, the culture conditions have to be well specified, and people have shown that if you culture it in fecal calf serum, it does work. However, it has some disadvantages. It can also be done with the human AB serum or platelet lysate. The platelet lysate really fulfills the criteria for the International Society for Cellular Therapy, and it is being found to be the best really medium to be used for culture. One disadvantage for the platelet lysate is that it carries the major histocompatibility class 1, and this could be a source for alloantigens. Now, what about pre-treating mesenchymal cells? If you treat it with like interferon or other inflammatory cytokines, you can boost the adhesive and the immunosuppressive capacity. However, you have to think about the drawbacks of pre-treating mesenchymal stem cells, and this is why we use it in the pre-treated mesenchymal cells in animal models, but in clinical studies we use the non-treated mesenchymal stem cells. Clinical production, you have to have, it's really important to have good cellular practices standards, quality management, and mesenchymal cell from cadaveric organ donors are not very practical for several reasons. We don't need to go into the details, but as you know, practically you need to culture and expand these cells, so it cannot be done. Autologous mesenchymal cells can be used, living donor mesenchymal stem cells, and third party, and there are actually 2 commercial products established by pharmaceutical companies that are available to be used as mesenchymal stem cells as third party. Now, number of mesenchymal stem cells applied, optimal cell dose still to be determined. However, what have been used in animal models and in clinical trials is 2 to the 10 times 10 to the 6 per kilo. More in animal models, the number is increased 5 to 15, but in clinical, 2 to 10 times 10 to the 6 per kilo, and you can look at those escalation. Route of injection is IV, but people have shown in animal models, in the rat model, that intraportal or intraarterial, be it in the liver or kidney transplant, could have advantages. Now this slide shows how we expand it. You get it from the bone marrow as a standard, and then you can separate the monoclonal cells in a density gradient. Then after that you culture it with fetal calcium, or recently the platelet lysates are used, and after you culture it, you reculture it after the cells are more than 70%. You have cellular cultures. You can put it in low density or cell density cultures again, and then you harvest it and they can give it to the patient. You collect the cells by trypsin. Now, what about concurrent immune suppression? Would you use concurrent immune suppression at the same time when you give mesenchymal stem cells? People have shown, be it in animal models as well as in the early clinical trials, phase 1 trials, that you cannot really, the drug-based immunosuppression cannot be entirely withheld. You have to continue immunosuppressive therapy, but you reduce it, and you have to be specific which one you can use. The calcineurin inhibitors interfere with the IL-2 pathway and interfere with the induction of the regulatory T cell. This is why they are not really, and I will show you the reasons why they are not considered optimal for continuation during the mesenchymal stem cell treatment. And as you know, cyclosporin is tapered in bone marrow kidney transplantation, and people have shown that you may reduce and stop immunosuppressive therapy in the early studies. However, this has to be confirmed in more studies. And I will show you later there is synergistic effect of the mesenchymal stem cells with mycophenolate, and this is what we use in the clinical trials, is mycophenolate and mesenchymal stem cells. Now this shows the effect of immunosuppressive therapy, drug immunosuppressive therapy on the mesenchymal stem cells viability. After 7 days, you can see the mycophenolate and rapamycin as compared to tacrolimus did not do much as far as the viability, and the cells were still viable, while with the tacrolimus it was not, with the increasing dose. Now this shows the effect of the immunosuppressive therapy on the MSC, mesenchymal stem cells proliferation and differentiation, it is really affected. Differentiation is affected, particularly the osteogenic differentiation as compared to the desmin or myogenic differentiation is not much affected. Now, as you can see, mycophenolate was the best as far as it is limited efficacy on the immunosuppression by the mesenchymal stem cells, which makes it really the drug of choice to continue, maybe with reduced doses during mesenchymal stem cell therapy. And also this shows that the mesenchymal stem cells, they don't have significant immunosuppressive efficacy on mycophenolate. However, for the other two, there is still, there is not complete inhibition by the other two, and I think this is significant as far as the use of mycophenolate as synergistic, its synergistic effect with mesenchymal stem cells. What are the potential risks? They are infusion-related, allergic-related. Maldifferentiation, they have shown that in certain animal models there are, differentiation into adipose ectopic bone formation. Some chromosomal abnormalities due to the expansion that you do for these cells, where you could end up with chromosomal abnormalities and malignant transformation, and the issue of homing and redistribution of these cells and where they go. There are some studies that show where these cells go when they are infused. Now, timing of infusion is important. This is under study. I don't think really there is a perfect recommendation or complete recommendation as far as before or after transplantation, the disease phase, be it acute versus chronic rejection. And the ethical consideration would be, what would be the value of this modality of treatment for solid organ transplantation in the face of the toxic effects of immunosuppressive drugs and chronic rejection. One would say that with the preliminary results, it is worth looking at it in more clinical trials. In kidney transplantation, you have to look at specific hard endpoints in these clinical trials: the incidence of acute rejection, graft failure, safety, logistics. Living donors, I think, are living donor kidney transplants are the most kind of recommended for the use of mesenchymal stem cells and the issue of autologous versus donor-derived mesenchymal stem cells. Now, there are several reports on the role and efficacy of mesenchymal stem cells in acute cellular rejection in kidney transplants, particularly as far as animal models. This is a study where there are 4 groups in the rat model. 4 groups of rats were transplanted, kidney transplants, and as you can see, group B and D. The first 2, A and B, were syngeneic transplants. The C and D were allogeneic, and the B and D groups received mesenchymal stem cells. And looking at the biochemical indicators and functional results for the renal grafts, looking at this is the creatinine level, creatinine clearance, proteinuria, and urine output, one could see that the group B and D, the one that received the mesenchymal stem cells, did the best with respect to the lowering the creatinine level and improving the creatinine clearance and other indicators. And this also shows that the group B and D that received either in the syngeneic or the allogeneic setting, they did the best as far as the histology, be it this histogram is for tubulitis, this is for vasculitis, glomerulitis, and this one looking at the cellular infiltrates, where the cellular infiltrates were mostly in the other groups, the group A and C as compared to B and D. Now, there are phase 1 studies as far as patients in kidney transplants, and this is a group from Italy where they looked at only 2 patients. They reported, actually, they had more than 2 patients, but the preliminary report just came recently, but 2 patients where they showed that the graft, and this was looking at the safety and the feasibility, that the patient had good graft and looking at the T regulatory cells ratio over the memory CD plus 8 T cells, that in the patients compared to the control who did not have mesenchymal stem cells, they have significant improvement in the ratio, and that they think attributed or contributed to the success of the grafts. Now, also in living donor transplant, this shows the dose-dependent immunosuppression by the perirenal fat mesenchymal stem cells. This was done from living donors kidney transplant. As you can see, depending on the dose, there is suppression on the mixed leukocyte reaction. Now, what about liver transplantation? For liver transplantation, again, the clinical trial, the animal and clinical trials showed both that you have to use mycophenolate, and there is advantage for regeneration of grafts. Now, this is a study that was published some time ago with respect to the mesenchymal stem cells that express the hepatocyte growth factors they express, and if these mesenchymal stem cells are manipulated in a way that they overexpress this factor, you could end up with significant improvement in the graft regeneration. And this slide shows in the animal model where this curve shows the survival of recipients of small 4-size liver transplants, those that received the mesenchymal stem cells that has overexpression of the hepatocyte growth factor as compared to the others. And this is the histology. This is for physiologic saline, and this is one for the group of animals that received the mesenchymal stem cells that has the hepatocyte growth factor. And this is the ALT levels, looking at the groups, and this is the group that did the best, and this is also looking at the weight of after the liver graft, and that shows that that group did the best. What about islet cell? And actually, before islet cell, we're going to talk briefly about heart, and this was one of the studies that was published recently. I think this was just a few months ago, where it was published looking at the pre-transplant infusion of mesenchymal stem cells, prolonging the semi-allogeneic heart transplant through the generation of regulatory cells. And this is also in animal models where it showed even when you look at doubling the number of mesenchymal stem cells, there is also an advantage. So it is dose escalation. And they showed that in this group of animals, just a single pre-transplant infusion of mesenchymal stem cells, they did much better than the other 3 groups. And they compared giving the mesenchymal stem cells via the portal vein, and this is the group, as compared giving it through the tail of, the tail of the rat, and comparing it to bone marrow and no cell infusion whatsoever. So there is significant improvement in the cardiac allograft survival. When you double the dose of mesenchymal stem cells, it is more sustained, which is really significant. Now, in islet transplantation, also there are animal models that have shown that you can improve the or protect the islet grafts from auto and alloreactive immune responses. In this study, they showed that the group that received mesenchymal stem cells, group of rats that received the mesenchymal stem cells, did much, much better than the other one as far as the protection of the islet graft. Now, when they looked at the glucose levels, as you can see, this is the group where they did very well, sustained steady state level, and this is the group that did not receive the mesenchymal stem cells, and these islet cells were engrafted in the capsule of the kidney. When they took it out, the blood sugar went up. So I think this is just an evidence of the role of the protection of the mesenchymal stem cells to the islet cell graft. Now, what are the future directions? First, there is evidence now from looking at the characteristics and the properties of mesenchymal stem cells and from the preclinical models that there is evidence to investigate it in larger clinical trials as far as patients in kidney, heart, liver, islet cells, and other organs. The study protocols should have stringent quality criteria, which should be reviewed by the expert consortium. And I think this was the decision of the study group I told you about, that they meet on regular basis, at least once a year, to look at all studies with respect to the mesenchymal stem cells used in solid organ transplantation. And time to an event of acute rejection and the frequency of rejection should be primary endpoints, and mycophenolate as a bottom-up protocol would be used in these trials. Now, the initial or the preliminary results that these, the use of mesenchymal stem cells is safe and feasible. Still, it's not clear what would be the best utilization, be it autologous versus allogeneic, and the most advantageous timing of mesenchymal stem cell infusion, be it before or after or at any specific time of the organ transplantation. Now, so far we use it as IV, but I think there could be an indication or evidence in the future that intraportal for liver transplant and intraarterial for kidney transplant could be a better way of doing it, and when we're going to use it as a therapy for acute versus chronic rejection. I'm going to stop at this point. Thank you.
Thank you very much, Dr. Hassan, for this nice presentation. Any question? For the end, okay. Now the next speaker, Dr. Eid Al-Mutayri. Dr. Eid is the Director of Lung Transplant Program and Consultant, pulmonologist and intensivist in the King Faisal Specialist Hospital and Research Center, Riyadh. He's graduated in 2003 from George Washington University in USA and completed fellowship in pulmonary